today we're going to look at gestational hypertension, which is one of the favorite topics of NCLEX, and you have multiple questions coming from this area. So this is very important that we focus on this particular topic. So gestational hypertension, as the name suggests, is nothing but hypertension that comes with your gestation or pregnancy-induced hypertension. So first and foremost, we need to know the classification. So gestational hypertension is classified as three. First is your gestational hypertension, second is your preeclampsia, which is gestational hypertension plus proteinuria, and then is your stage with eclampsia, where you have gestational hypertension, proteinuria, and active seizures. Now, coming to a pregnant woman, let's look at what are the predisposing factors or risk factors why a particular person can develop gestational hypertension. So when you're looking at the predisposing factors, the first is if it's a primi gravida. A first pregnancy has higher risk of developing gestational hypertension. An age of less than 19 or over 40 years of age. If the person has an existing chronic renal disease. If somebody has a chronic hypertension, diabetic mellitus, during pregnancy if there is an Rh incompatibility, and a history of gestational hypertension. These are the patients who are at a higher risk of developing hypertension or gestational hypertension during that present pregnancy. When you're looking at the signs and symptoms or the assessments that we do is, as the name suggests, it's hypertension. So obviously the person is going to come with a high BP. So high BP is your first indication that there is a risk of gestational hypertension or preeclampsia to that person who is sitting right in front of you. The second thing is proteinuria. So you know how during your periodic visitations during the pregnancy, your urine is getting assessed for albumin or protein content. So at a point when they see a proteinuria, that is when the suspicion of gestational hypertension goes in and the diagnosis is made. So one thing, investigation that you do is a 24-hour specimen collection, and based on the level of protein, if it's 0.3 to 2 gram, it's mild, and if it's more than or equal to 5, it's a severe problem. So based on that is how you know or categorize your gestational hypertension. Now, coming to the management. So like I said, you have three categories of gestational hypertension. So management is also dependent on which stage are you at. So let's look at a scenario wherein you have hypertension, but you don't have any complication. So you would be monitored, you would be administered antihypertensives, you would also be asked to do dietary management. So dietary management is high carbohydrate, high protein, and low salt. And also maintain your intake output. Make sure that you drink enough fluids and make sure that you are outputting in accordance with your input. Also, watch for neuro changes. Neuro changes are an early sign to tell us that there is something going on in your body which is causing the neurological system to get irritated. So when you look at the deep tendon reflexes, what are you going to see? You're seeing hyperreflexes or you're seeing clonus. For severe preeclampsia, the recommendation is magnesium sulfate controlled infusion and bed rest. Why magnesium sulfate controlled infusion? Because magnesium sulfate itself, even though it's a treatment, if it's given in excess, can cause toxicity. So when you put a patient on magnesium sulfate infusion, it is recommended that the person is connected to a continuous ECG monitor. The vital signs are checked regularly. And magnesium sulfate infusion is always given through a controlled pump. So you set the pump in accordance to the recommendation, put the bag on, connect the person to a continuous ECG monitor, and then watch for the blood pressure to drop. While you're doing it, it's also very important to know the signs and symptoms of magnesium toxicity. Let's look at signs of magnesium toxicity. So it is flushing, decreased deep tendon reflexes, poor urine output, central nervous system depression, respiratory depression. Now, this magnesium toxicity, when you have someone on magnesium infusion, you can't always guarantee that the toxicity is not going to happen. So that's the next thing as an intervention from nurses side, what we have to do is always keep calcium gluconate at a point of easy access. What calcium gluconate does is an antidote for magnesium sulfate. So whenever the physicians put the order, they would also have an order for calcium gluconate in case of magnesium toxicity. So you notice the signs and symptoms, calcium gluconate should be at an easy access point so it can be administered to prevent it or treat the complication. When you're looking at eclampsia, what we were talking about is preeclampsia. So you have high blood pressure and proteinuria, but the patient has not yet had seizures. Now, eclampsia is a situation where the person has seizures. What do? You remain with the client, because when you have seizures, that's all you can do. Once the seizure is settled, you monitor the blood pressure, look for the fetal heart rate to see if there is any fetal distress. Preferably position the patient on the sideline position so the blood flow is not affected and the fetus gets adequate blood flow. In addition, sideline position can also prevent aspiration. Most important, airway. You always have to prioritize your airway. So post eclampsia, make sure that the airway is open. If the person requires it, put in an airway once the seizures are done to make sure that the airway remains open if there is any other further complication. Also administer oxygen 8 to 10 liters to make sure that the oxygenation status is maintained. Couple of other things that is very important with preeclampsia is we've talked about how to prevent or manage it, how to treat it. It's very important we also know what are the potential complications so we can identify if any of those complications happen. So the potential complications of untreated gestational hypertension would be abruptio placenta, DIC, disseminated intravascular coagulation, thrombocytopenia, intrauterine growth retardation, placental insufficiency, fetal death, and HELP syndrome. HELP syndrome is a synonym that we use to refer to hemolysis, elevated liver enzymes, and low platelet count. So those are the complications that can happen with gestational hypertension. So as nurses, our responsibility begins with educating your patient to make sure that they are aware of what lifestyle changes they need to make, the importance of compliance to the medication therapy, as well as identifying the potential complications or identifying the worsening of their condition, and the management of eclampsia and preeclampsia. Also remember magnesium sulfate therapy and the signs and symptoms of magnesium toxicity.